Hello and welcome to our webinar, Talking to Your Doctor About Dementia. I'm Mike Bias with the Alzheimer's Association in Illinois, and before I introduce our speaker, I just want to call your attention to the bottom of your screen. There's a Q&A pod. Now that's where you can type in any questions or comments that you have for our speaker today. Just to let you know, although he is a neurologist, he's not going to be able to answer any specific questions about a person, because of course he would have to do an exam on that person. But any questions that you have in general, we'll be glad to give to Dr. Gittleman. Just to let you also know, these are confidential. Nobody else, other than the doctor and myself, can see your name or your question. So, our speaker today is Dr. Darren Gittleman. He is the Senior Medical Director at Advocate Medical Memory Center in Park Ridge, Illinois. He's actually a triple board certified physician. He's in neurology and internal medicine and behavioral neurology. So, welcome, Dr. Gittleman. How are you?
Thank you, Mike, and thank you so much for having me on today.
It's great to have you here. The title is Talking to Your Doctor About Dementia. Before we get into all the specifics about how people can prepare for a doctor's visit and things that they should expect and not expect, I just got to ask you, is there one specific thing that kind of drives you crazy as a neurologist about when people come and they're concerned about dementia? Or is there something that is the hallmark of these visits that it's like, oh, here this is again?
Well, I think obviously when people are going through this, it's disconcerting for the patient and family. And what I need the most as a doctor is to understand what's happened to the person, what the symptoms are, and what the timeline is of those things. And it really helps us a lot when families in particular, or the patients sometimes, have written down some of the symptoms they have, so they're able to communicate that and also know maybe what questions they have as well. So getting those details about the background of the patient, details about the timing of the symptoms, and details about the symptoms really can make a big difference in thinking through what's going on with the individual.
I heard one of these motivational speakers talking about, success and goals, and he said, you've got to be very specific. He talked about talking about goals, and a man says, yeah, I have a goal to become more wealthy. So he says, I handed him a nickel, and I says, there, you've achieved your goal. And although that's kind of humorous, I can imagine that it would be very frustrating for you as a physician for people to say, well, mom or dad has memory problems, and they're not specific, because what is that? I had a memory problem early this morning. I couldn't find my keys. Well, right. That's a lot different than, yeah.
Well, I would never say frustrating. What I would say is my goal in the visit is to try to walk people through the symptoms and provide them a diagnosis and then treatment and support. So my goal is to help them, and their goal is to help me help them.
Gotcha. Well, let's start off by talking about an accurate diagnosis and why that's important. I think the number one question that we get asked at the association is, what's the difference between Alzheimer's and dementia? And frequently I'll hear people say, oh, Grandpa was diagnosed with dementia, and then it went into Alzheimer's, as if Alzheimer's is a progression. So how do you explain to people, when they ask you, what's the difference between Alzheimer's and dementia?
Thanks for asking that question. That's actually maybe the most common question I get asked as well. We now know through research over the past 10 to 20 years or so, through autopsy studies, through imaging studies, genetic studies, and so on, that the underlying changes in the brain for problems like Alzheimer's disease or other causes of dementia start many years before the symptoms become apparent. And so as things progress over time, people progress through a series of stages of their overall, what I'll call clinical status. So their early clinical status is something we would call mild cognitive impairment, where there are changes in the person's thinking abilities that can be noticed by family members, for example, or on objective testing, some of the tests that the doctors or a neuropsychologist would give the patient. But the individual is really performing quite well in their daily life. They're really quite independent, but family might notice, for example, that they're repeating themselves more. over time, many of those individuals are going to progress. The symptoms will become more significant. There'll be more and more memory loss, and it will then get to the point where the person is not able to fully perform all their daily living activities independently. Usually that will start with the harder types of daily living activities, for example, managing their finances or taking all their medications on time, or preparing a complex meal, for example. They'll begin to struggle with that. And then later on, simpler daily living activities might be affected, things like even like dialing the telephone or eventually managing their own personal care. So once it goes from the person having symptoms but being independent to the person having more symptoms and then not being quite independent, that's what we call dementia. So dementia is a general clinical term. One might call it a syndrome in a way, because there are many symptoms that accompany it. But I guess the sine qua non, or the point, is that the person has problems in their thinking and they're no longer independent in their daily life, and that the problems are usually progressive over time. So not just a one-time thing, but there's usually a progression of symptoms over time. Underlying dementia, of course, there are many different causes. Alzheimer's disease being the most common cause when people are of an older age, or as people get older over time. But there are many other types of dementia as well. Strokes can cause a vascular dementia. There are disorders related to Parkinson's, which we might call Lewy body dementia or frontal dementia. But Alzheimer's is most common, so people at baseline will have that dementia that has progressed over time, and then the doctor is going to also try to determine what is underlying that.
So it's kind of like cancer. You hear so-and-so has cancer, and usually the first question is, well, what kind of cancer?
Exactly.
And so, what is causing the dementia? Now, what about those who say, well, if you've got dementia, you've got dementia. It doesn't matter what is causing the dementia. Is it Alzheimer's or dementia with Lewy bodies? Because, it's affecting your thinking, so it doesn't really matter. Just write me a prescription. What would you say to that?
Well, I would say to that it can matter a lot. I mean, it can matter a lot to the person, to their family, and to the physicians treating them, because different dementias cause different symptoms. They have different prognoses. They require many times different treatments. Currently for Alzheimer's disease, we do have some treatments. We don't have a cure, but we have some medicines that can help a little bit. We don't have as many of those medicines for other types of dementia. And there are certain treatments that might be acceptable for certain types of dementia and yet may cause side effects in other types of dementia. So, for example, Lewy body dementia, which is related to Parkinson's disease, those people can have a lot of psychiatric types of symptoms, hallucinations, for example. And some of the drugs that we use to treat that when they're out of hand or causing someone to be quite agitated, we can't use in Lewy body dementia. So thinking of that diagnosis, making that diagnosis, may save the person a lot of side effects from those types of medicines. But I think it's important in terms of the patient and family being able to plan, to know what to expect, to know the kinds of symptoms that may come up, and to have the proper treatments and the proper investigations. It's important to think about what the underlying dementia is.
So, when we hear somebody says, well, mom or dad or whoever is diagnosed with dementia, the first thing I think of is, well, what kind of dementia? And if you don't know, is it a general practitioner who diagnosed it, which is fine for the diagnosis, but are you seeing a neurologist who can then differentiate between the causes of dementia, and that will inform your treatment? Because, as you said, drugs that you might give to somebody with Alzheimer's to help with certain symptoms might make it worse if it's dementia with Lewy bodies, for instance.
Exactly. Well, our general primary care practitioners do so much nowadays, and have so much to do for care for patients. That is a job that is increasingly complex, and I don't envy them. And they often have very little time to sit with people. I mean, I think the best ones, try to make the time, but going through a diagnosis of dementia is complex, and it involves measurement of neurological symptoms, cognitive symptoms, behavioral symptoms. So many times the primary care practitioner, what they can do first is recognize that there's some problem there, and then refer to someone who can spend that additional time trying to make those additional diagnoses. Sometimes, and then knowing what test to order, and then knowing how to use the medicines in a way that's most advantageous to the patient. So, I would recommend seeing someone. Can be a neurologist, but there are psychiatrists, particularly geriatric psychiatrists, who might be very savvy in that diagnosis, and geriatricians may be particularly savvy as well, in addition to behavioral neurologists and general neurologists at making that diagnosis.
Okay, so we understand then that dementia has many causes, and depending upon the cause of the dementia, the treatment can vary. So it's important to understand a thorough diagnosis, a complete diagnosis would be not just they have dementia, but rather they have dementia most likely caused by Alzheimer's, vascular dementia, dementia with Lewy bodies, what have you. But now, we're talking about all of these diagnoses. You, I'm sure, have people who come in and you say, nope, this is not dementia. And, one of our concerns is that people are, we saw a study that said that more people were afraid of Alzheimer's than they were afraid of death.
Exactly.
And we want to get people to the doctor and let them know, you know what, you've got these symptoms, you're not a doctor, you're not a neurologist, and you don't know if this is Alzheimer's or not. Go to the doctor. So what are some things that might cause some symptoms that aren't Alzheimer's at all, or other dementia, that you can quickly reverse?
So I see patients like this all the time, Mike, and that's a really good question, and it just points out the importance of getting a proper diagnosis and having the proper investigations. So we certainly see people, for example, particularly older individuals are susceptible to this, but people at the younger end of the old age spectrum, in their 50s and 60s, if they're quite sick, people who go into the hospital and are very sick, for example, can develop what's called a delirium, in which they are confused and not able to focus their thoughts. And this is a product of their medical problems at the time of going into the hospital, or they have some significant infectious illness, or they're undergoing, they've had trauma or a surgical procedure, or even medications. So they'll develop quite significant confusion. To someone who's not aware of this, it might look like dementia, because now the person's confused, they can't take care of themselves. But the difference is that this has been the acute and sudden onset of these symptoms, rather than something that's more chronic and progressive over time. And many times, as the medical situation improves, the surgical situation improves, or a medication is changed, though that person will improve and get back to their baseline. So making that diagnosis is very important, particularly for hospitalized patients. We often see people who are on medicines that have centrally sedating properties. They may be taking opiates, but maybe too many opiates, or they may be on medicines such as Valium, which we call the benzodiazepines, or they will even be on certain medications for their urine that have a property called the anticholinergic property. Some of those medicines have that property, and they can lead to a lot of confusion, and changing the medicine may lead to a quite significant improvement in the person's mental status. Other things that can, I should say, masquerade or appear as if the person has a dementia, we always check for deficiencies of certain vitamins, such as B vitamins, changes in the thyroid function, unsuspected anemias or changes in liver or kidney function can lead to problems with thinking. And in the past, we checked more for certain infectious disease, such as syphilis. Chicago, as an urban area, unfortunately, is endemic for that infection, even though it's not as common nowadays as it used to be. But there's a treatment for that. Penicillin cures it. So we check for that as well. And in other populations, you may want to check for problems such as the AIDS virus and so on. So there are a lot of different diagnoses that are considered when evaluating a person for the possibility of dementia, because when we say someone has a dementia or a disease causing dementia, We are saying that they have a neurodegenerative disorder that is progressive over time and that is likely, permanent, that is going to be with them for the rest of their lives and that we'll have to manage chronically. That's a significant step. And so we want to make sure we've ruled out things that have other types of treatment before making that diagnosis.
So we had a woman in central Illinois who went on vacation, and she came back from vacation and said, suddenly my mom had Alzheimer's. So she took her to her doctor, and the doctor said, I'm going to change her medication. And the daughter said, well, this doctor's crazy. She's been taking that medication for years.
Mm-hmm.
And a week later, mom didn't have Alzheimer's anymore. So is that a case where as we age, our body metabolism changes and suddenly we find that our medications need to be adjusted?
Could be. Maybe she took extra medication. Maybe she was put on a medicine that interacted with that medication and made the levels in the blood more significant. Other problems I've seen people with severe sleep apnea, for example, where the number of times they're waking up in an hour is basically once a minute. And with treatment of that, dramatic improvement in the person's mental status. And then, of course, we do see some people who may have what we call subclinical seizures. They don't have an obvious convulsion, these little periods of fogginess. And you investigate that, find out there may be a seizure. Putting them on an anti-seizure medicine can be life-changing for that person. Those foggy episodes going away, and they're able to, manage themselves, quite well at that point. So there's a very long list of these types of problems, but we try to consider them when evaluating a patient.
So now, obviously, a stroke is a sudden thing, and that's going to affect your cognition. But aside from that, is it fair to say, as a rule of thumb, knowing that rules of thumb are never perfect, but if it comes on very quickly, it's probably not Alzheimer's, because Alzheimer's comes on slowly and gradually over time?
Yes, there are very rare instances where people who are eventually determined to have Alzheimer's disease can seem to progress more quickly than usual. But more quickly than usual means instead of progressing over a number of years, many years, they might progress over a year or, a few months to a year. Alzheimer's disease does not come on like a snap of the fingers. And when people have those kind of sudden changes, we absolutely then think of problems like I mentioned, delirium, where there can be the acute onset with a medical problem and all the medical issues that can cause delirium. Or, as you notice, we think of stroke, because stroke can happen suddenly and kind of synergistically or interactively worsen the person's mental status more than if they weren't having problems beforehand. Or these subclinical seizures. So things that come on suddenly are very different than the usual disorders like Alzheimer's.
Okay, and before we move on then, the last thing I wanted to ask is, we hear this term preclinical, the preclinical stages of Alzheimer's. What does that mean?
So preclinical, as I mentioned before, we know that the pathological changes in the brain take place many years. So Alzheimer's disease characterized pathologically by these plaques and tangles. We now know the amyloid protein that comprises the plaques actually begins to deposit 20, 25 years ahead of time. The tangles themselves probably start about 15 years ahead of time. So as these changes advance in the brain, at some point they advance to the point where the symptoms become apparent. So preclinical is when really those symptoms are, or prodromal now, they'll call it, where we're just beginning to get the hint of those symptoms, but it's so subtle at that point, you don't really know that you couldn't really make a definitive diagnosis. Nowadays, particularly neurologists, behavioral neurologists, people who see these patients all the time will have sophisticated methods for trying to pick up essentially these prodromal or preclinical types of cases. Traditionally, we would get a laboratory test, we would get a brain scan to look for stroke, and we might do more sophisticated memory testing, which is called neuropsychological testing. But as preclinical implies, you might do neuropsychological testing, and particularly when people are at a higher level, the neuropsychological testing may say they're performing, let's say, in the high average range. Well, maybe we don't know that. Maybe that person was superior before, and now they're high average, but they still look a lot better than people with dementia. And in that case, we wouldn't necessarily be able to make that diagnosis early on. But if we do the very sophisticated testing, PET scans, for example, or we look for what are called biomarkers or proteins that we can measure in the spinal fluid, then we can we might be able to we would know the process is going on in their brain ahead of time, and suggest that that's something we're going to have to monitor closely because they may, in a sense, have the pathology, so they're preclinical.
Gotcha. Okay. A lot of terminology to understand. So let's look at diagnosis now. I remember, as an Alzheimer educator, I had a lady tell me that she had been diagnosed with Alzheimer's and she had tears in her eyes. And I asked her a little bit about that, and it turned out that she went to a senior citizens fair. Mm-hmm. And at that fair, they had hearing screenings, and they had chiropractors there to check out your back and all sorts of free information, and somebody was there doing memory screenings. And they asked her 20 questions and basically gave her a score that suggested that she had cognitive issues, and she heard, well, I must have Alzheimer's. So talk to me about memory screening. Is there a single test that you can give to somebody, a blood test or an assessment that single test can allow you to diagnose Alzheimer's disease?
Well, that would make the diagnosis a lot easier. For certainly, no, there's no blood sugar test, as it were, for Alzheimer's that we could do for diabetes, for example. And because the brain can be affected in so many different ways, testing people and understanding the deficits can be quite complex. Most commonly, people with Alzheimer's are going to have memory problems, but sometimes they can present it first with language problems or visual spatial problems or behavioral issues. And it's only with more detailed testing that you're going to pick that up. Of course, everyone starts from a different baseline. You'll have people come in and say, well, they never had a great memory. Well, maybe they never did have a great memory, and you have to try to pick up what their baseline might have been and how they're performing now. Or many times these tests can have certain cultural biases to them or educational biases to them that you're just not going to pay attention to in the screening environment. So someone who is highly educated, postgraduate levels of education, versus someone who maybe only had a third grade or education or less than high school, they are just naturally going to perform differently on these screening tests. But it could be that someone who scores lower, but kind of at the upper end of someone who's uneducated, may be doing better than someone who has postgraduate level of education and is missing too many points. So all of that has to be taken into account, and doing what I would say is what we do in the clinic when we do a basic test. You may hear about the mini mental status exam test, or the MOCA, the Montreal Cognitive Assessment, or the St. Louis University memory screening. All of those tests can be done in somewhere between 5 and 15 minutes, so they kind of give an overview of what's going on. I like to think of it as they kind of lay out sort of the basic landscape of where, what the symptoms might be. But you also have to realize the person you're dealing with, what their background is. We always ask about that, and how they performed on the test. And as I mentioned, someone with a highly educated background, even if they miss 1 or 2 points, that might be significant, while we may allow more in someone with less education. So taking all that into account, we do the basic tests to get a sense of things. We listen to the patient, because that's most important, in the family. Even when the tests are normal, if we're hearing all kinds of problems, we pay close attention to that, and then send them for more sophisticated testing. So as you noted originally, I would say the 10-minute memory screening is not sufficient to absolutely make a diagnosis. It may give you a sense that there's a problem there, but it can also miss problems. So you have to take everything into account when making an assessment from that.
So uh, the 10-minute memory screening is one tool, and I would hazard to say that I could pass that and perhaps have dementia, and I might fail it and not have dementia.
Exactly. Exactly. Now, I wouldn't say you could fail it terribly and not have dementia. There are certain limits to that. But there are definitely the other way, people who, quote, pass in their primary care physician's office, where they may do a very basic type of screen. And yet when they come in, we are hearing from them and their family that there really are problems that this person is having, that in a way, the more sophisticated test of life is impacting on those people. So they might do well when you say, well, what year is it or where are you? But when they have to multitask, set up a dinner, engagement, for example, or travel plans, or put together a meal, or get together all the paperwork for taxes, now they're really not able to do that. And that also tells you a lot.
Gotcha. So what is involved in a diagnostic step? So, I'm concerned about a loved one. They might have, Alzheimer's, because, as an uneducated person, uneducated in the field of dementia, I'm not a neurologist. I just think, well, if you got memory problems, it's Alzheimer's, not understanding the subtleties. And is there anything that I should know that the doctor's going to do? Because I'm thinking, hey, the doctor's got a magic wand and he's got a bottle of pills and it takes 5 minutes. So what do you have to do if you're presented with a person that's presenting these issues to diagnose them?
Well, all doctors have magic wands. I keep them. I'll just show you. I have my little black bag that I bring in with me.
Marcus Welby had one of those.
Exactly. We keep the magic wand in there. So I think I mentioned a little bit before, but just to kind of go over it again, first and most important is listening to the person and listening to the anyone who accompanies them, their family, for example, and seeing what the symptoms are cognitively, behaviorally, functionally, and that's really, I think, the most important part of the test, quite frankly. Then we go through the rest of the exam. We'll do some basic screening thinking test. We'll do a neurological exam looking for differences in motor or sensory or reflex function or their balance. And then as far as tests to order, once we see we've gone through this, we'll, I would say at the most basic, order some basic labs. I've mentioned thyroid and basic chemistry and blood count panels, B12, folate, probably syphilis. If there's something in the history to suggest other infections or other medical problems that the person has, there might be labs to get for that. For example, if the person had a new onset arthritis or headaches or what have you. We would usually get a MRI scan. If the person can't tolerate that, a CAT scan. Often that's done without any addition of contrast, but if there's some reason to think the person has inflammation in their brain or infection, there might be contrast added to that. If we thought the person was having episodes of problems, episodes of fogginess where seizures might be the case, we would get an electroencephalogram. And then particularly if the person is very mildly affected, where we would like to get a baseline of their thinking status, or there may be some interference in testing because the person's unusually anxious, or they might have a learning disability, so that we want to get more quantitative testing of their thinking abilities. We'll do neuropsychological testing. And that's really kind of the basics of what's done. Beyond that, it would depend upon how those results come back and whether more sophisticated other types of scans are needed, such as the PET scan, for example, or a spinal tap if we're concerned about a young person with dementia symptoms where that's not very usual, or infection or inflammation.
So this sounds like it would take a little bit more than 10 minutes. And I think that's important for people to understand, especially when you're going to do a urinalysis and a blood test, and they might say, well, I'm suspecting a problem in mom's brain. Why are you checking her urine? So they need to understand that you're going to do a total workup to rule out a lot more benign possibilities than.
Yes, and I'm really fortunate at the Memory Center. We are fortunate that we take longer, I would say, than sort of a general neurologist or certainly a primary care doctor has the time for. We're lucky that we can be generous with that time. Most initial evaluations will take up to 90 minutes to go through all of those details and then answer, provide enough time to answer some questions at the end. Even before there's a diagnosis, people are going to have a lot of questions about what to expect and what's coming up. And we try to at least provide some initial advice, and maybe we'll get to that in a subsequent slide, about things that they can do without medications to try to help themselves, get rest, exercise, eat healthy, and so on. So it takes a fair amount of time to go through all that at the initial visit.
So to be clear, then, if you've taken your loved one to a general practitioner and they have just a standard office visit, and they write a prescription for Aricept or some other Alzheimer's drug, that's not sufficient. And obviously, Dr. Gittleman is talking about taking a 90-minute full look at all of the different dimensions here of the body and the brain to ensure that there's an accurate diagnosis. First of all, do you have dementia or not? And second of all, if you do have dementia, what is causing the dementia? Is it Lewy bodies? Is it Alzheimer's? Is it Pick's disease, frontotemporal, what have you? Mm-hmm. So that's very good to understand that it's not just a 10-minute test.
Not usually, and I will say, look, a person's primary care doctor, they may know that individual for decades and really have a good sense of them. So even if they're spending a short amount of time, there are those primary doctors who are very savvy, know that individual super well, and are, in a sense, it may be a 10 or 15-minute visit, but it's more than that just because they know that individual so well. And so some primary doctors are able to provide that and provide an appropriate treatment. But I think in the majority of cases, there are some additional investigations that are needed and a more specific, because Alzheimer's disease in people over the age of 65, more than 2/3 of the patients with dementia will have Alzheimer's. So if you were taking a random shot at a dartboard, as it were, and just guessed Alzheimer's, you're going to be right most of the time in older individuals. But to be more sure of that diagnosis, then I think the additional investigations are necessary.
Great. Well, that takes us to our next thing. How can we, as laymen, prepare to make your job a little bit easier? We used the example earlier of, not being very specific about, I want to be more wealthy, and, well, I got a nickel, I'm more wealthy. So what can somebody do ahead of time to make the most out of the visit and to help you do your job even more effectively?
Well, a number of things that we've alluded to before. Having a sense of what the timeline is. Many times families will come in and say that, things have started very suddenly, and what may be is sometimes there's the acute or sudden discovery of a chronic process. Perhaps the children and mom or dad were living separate, obviously separate from each other. They're all adults, and but yet maybe somebody moved into the city or something like that, and now they're seeing mom or dad more, and now, wow, they're really noticing there's a problem with the finances and things like that nobody had recognized, and so suddenly everything seems worse. But trying to get a sense of what the timeline is. When did the symptoms start? How many weeks, months, years has it been? That really helps a tremendous amount. And then having, I would say, a general sort of catalog of symptoms with some, I don't think you need every specific example, but with some examples. So, for example, well, we notice mom repeats herself a lot, and, in conversation, she'll repeat the same question several times. Or she's not remembering her appointments. For example, she had her hair appointment, which she has every Monday, and she's been missing those hair appointments. So I don't think you need to list every appointment that's missed, but that gives the doctor the idea of the kinds of symptoms that are coming up, or that they're having trouble coming up with words, or that they are just not so aware when they're watching their favorite show on TV. They don't really seem to be aware of what happened in the episode when it's all done, and so on. So just kind of a catalog of those kinds of symptoms, some specific examples to give the doctor a sense of what's going on, an understanding of the timeline. Those things really help. And then, of course, just the rest of the exam, it's important to know the rest of the person's medical history. What other chronic medical problems they have, surgeries, family history, social history, educational history. All of those things add in and are important for the doctor to know.
Okay, and again, being specific, everybody has walked into a room and they forgot what they went in there for. Everybody misplaces their keys. So by saying, well, mom forgets things, that's not really helping you, but giving some specific examples, and we say here, prepare a log or a journal to just kind of keep track of those things, because it's easy to forget. I was like, oh, wait a minute. 3 times yesterday, mom said, what are we having for supper?
Exactly.
And so you want specifics so that you know that this is not just stress, or it's a normal thing that we all experience.
Yes, exactly. And in fact, we all experience. All of us misplace our keys, wallet, repeat ourselves, tell the story more than once. Might be half listening to a conversation. It's like, oh, what'd you say? All of us go through it, but it's really when the symptom starts to take over the person's life, or truly begins to interfere with their ability to think through a process, manage their daily affairs, that's when you're really going to start to notice it. So noticing when those problems occur and how they interfere, I think, is very important as well. And as you said, not just to say, because we do have some people come in and they say, oh, mom has memory loss. Well, what's the example of that? And they don't really know. And again, we're making a serious diagnosis with long-term consequences. We really want to have those specifics to make sure that we haven't missed something.
Great. And then, doctor, the other question is appointments in the afternoon or the morning. A lot of people know that with Alzheimer's or other dementias, there's something frequently called sundowning, where as the day goes on, the person's symptoms tend to be more on display, and they have a harder time in the afternoon than the morning. Would you say, if all things being equal, that you would rather see that person in the morning or the afternoon, if indeed that day is the morning they're doing better and the afternoon they're doing worse?
Good question. I guess I'd rather see the person when they want to see me, because they're more likely to be able to get through the evaluation. So that I think is important. I don't really see clinically, people do vary, but in the time slots for the standard clinical appointments, sometime between 9 and 5, most people are pretty good in that time. Sometimes they will be fading towards the end of the day. I don't think there's really any need to have an appointment at a particular time. When a lot of people are having the most trouble, we hear about that sundowning. It's often very late afternoon or early evening, probably going to be beyond where the doctor's appointments may necessarily be. And in that case, make some notes about it and tell the doctor, what's going on. I think that would be helpful. And although clinically it doesn't matter so much, I will mention that for research, the timing of appointments can matter a lot. So there are definitely research studies we're involved with where they say they would like the patient to show up right about the same time at every visit, because in Alzheimer's disease studies, you're going to be rating that person in their memory, their behavior, and so on, and you want a very consistent set of ratings over time, except where the drug is making a difference. So you don't want it the case that they come in the morning and they're super, and the next time they come in the afternoon, they're not so good. Well, was that because the drug didn't work for them, or was that because they came in the afternoon? So in that sense, research is often sensitive to that. But as a matter of clinical assessments, that's not usually as much of an issue.
So another thing is that we've heard is, I take mom to the doctor. She won't let me go in and talk to the doctor. And every time she sees the doctor, she seems fine, and it's the morning, for instance. But then, as the day progresses, she gets worse, and it's very clear to us adults, children, that there's a memory issue here. But the doctor isn't catching it, and we can't talk to the doctor because of HIPAA. Now we tell them that that's not actually true. The doctor can't talk to you because of HIPAA, but the doctor could get a letter from you or a phone call, and they can listen to what you have to say. They just can't share mom's medical information with you. So, is something like that helpful, where you would get a written communication ahead of a visit that, hey, we're concerned, and here are our concerns, and let me be specific?
Yeah, that's actually super helpful. And that does happen at times where, unfortunately, with these disorders, it often affects our ability to have insight about ourselves. So, of course, we each have a kind of picture of who we are and how we perform in the world. And in these disorders, particularly Alzheimer's disease, where there's dementia, the patient may really feel that they're doing absolutely fine, and the family is really seeing a very different picture than the patient. We always point out to people that, in a sense, there's not enough evidence in the world to convince the patient that you're right and they're wrong. And so we don't try to argue with people. I think that doesn't usually produce a useful outcome, but we try to enlist them in trying to help themselves. And similarly, when we do have some patients who will say, well, I don't want you telling my husband or my daughter or son or whatever, we just try to work with them over time so that they can trust someone in the family. They may not trust everyone in the family, but at least someone who can look out for their interests when necessary and provide them some assistance. I think that's so important. That brings us to a larger issue, just as a diversion for a moment. I can't tell you how important it is for all adults, I think, to make advanced care plans. People should think ahead of time, what they want out of life, what they'd like their life to be, and what they would like to happen if they were quite ill, or who they would like to have help them make medical decisions if they were not able to make medical decisions for themselves. These are hard discussions. These are hard thoughts to have, but a person would really like to make those choices for themselves and not have others impose things on them without them having decided who's going to make those decisions. Having a power of attorney lets someone set up ahead of time who's going to make healthcare decisions if you can't make it, or who's going to manage your property or finances, for example, instead of having that taken away from the person. So those are really important conversations to have, so that your loved ones know what it is you want when you're in a situation that you can't make those decisions at all. So anyway, enlisting family members, we try to do that so that someone can understand what's happening with the patient, because you may tell the patient about their diagnosis and symptoms, and they may go home and say, well, everything was fine at the doctor, when really the doctor didn't say that at all. So having someone who can also feed back to the patient and know what's going on, I think, is very important.
Great. We're going to go on to the next slide here. I want to let you know, if you're logging in live and you have any questions for the doctor, at the bottom of the page, the Q&A pod can be used to send in a question or a comment confidentially. Only Dr. Gittleman and myself can see it. No one else can see your name or your question. Not if you're watching this via a recording, though. That Q&A pod won't be active. So let's look now at living with dementia. Once the diagnosis is there and you're treating the person, what can we expect from medications? You mentioned earlier that there's some treatments, but they don't cure Alzheimer's.
No, so the only treatments available for Alzheimer's disease, the last time a truly independent drug was approved was 2006, which just tells you how hard a nut this is to crack. There have been 150 clinical trials, at least, between about 2000 and now, for drugs, and we really have not yet come up with a new medication since 2006. So there are essentially 4 medications approved. There's a set of drugs called the cholinesterase inhibitors, and they block the breakdown of a nerve transmitter called acetylcholine. that's a very important nerve transmitter for getting our nerve cells kind of tuned up and working the right way and helping our memory system work. Donepezil, galantamine, rivastigmine, those are the three cholinesterase inhibitors. They really are all approximately equivalent in their effectiveness. Some of them are a little better tolerated than the others, but even if one isn't tolerated, it's often useful to try a second one or a third one. So we often start with donepezil, for example, but other physicians might make other choices. And by boosting this chemical called acetylcholine, they slightly improve in a sense, the signal to noise or the functioning of nerve cells in the cortex and memory system. And so that people sometimes are kind of a little more focused and with it. Families will say, oh, they weren't remembering that phone number when they took a phone call, but now they kind of remember that, or they're, kind of taking care of some of their daily affairs a little better or a little more focused on conversations. That's what you'll hear, even though they don't fully get rid of all the symptoms. In people with more moderate disease, memantine is a choice and can be added on. So those medicines can be added together. And memantine, again, just helps the nerve cells function a little bit better so that there's subtle improvements in thinking and in daily functioning. The medicines sometimes also help behavior. And in many cases, in people who may be agitated, for example, sometimes starting one of these medications to help the person's cognition can actually result in improvements in behavior. And in many ways, these medicines are safer than some of the psychiatric medications that are used. So now, the medications are approved for Alzheimer's disease, and that's all that they're approved for, except rivastigmine is approved for Parkinson's disease-related dementia and by extension, Lewy body dementia. And the medicines also, there's a fair amount of clinical trial evidence that the medicines can be helpful in vascular-related dementias, even though they're not approved for it. None of the medicines have clearly been shown to help in frontal-type dementias, for example.
Now,
yeah, go ahead.
Oh, I'm sorry, doctor. The medicines help with some of these symptoms, but they don't slow down the progression of the disease in Alzheimer's.
Good point, Mike. They don't change the underlying progression of the disease. As far as we can tell in the clinical trials that were done, people on medicine, people on placebo, you followed them over 6 months or a year. People on the medicine seem to be better than the people on the placebo, but as soon as you took away the medicine, the people on the medicine now were right back where the people on the placebo were. So that it was really a symptomatic benefit rather than a disease-modifying benefit at this point. But that can make a difference. There have been studies to suggest that these medications can reduce the amount of time that caregivers may have to help the patient. They can somewhat delay placement to a nursing home, for example, and they can help people function a little bit better in their daily lives, and I think that's important.
Unfortunately, though, Alzheimer's currently, until we find a cure or better treatments, Alzheimer's always wins. It's a progressive, fatal disease, and we're all waiting with bated breath for better treatments that are more effective. So, should everyone take medication?
Perhaps. I think that's something that needs to be assessed again on an individual basis. Depending upon the diagnosis, we will often try people on the medicine, and then we follow up and assess them over time. Does the medicine seem to improve their thinking? Does it seem to improve their daily functioning? Or in some cases, patients or family may say, you know what, I don't see a lot of improvement. On the other hand, they really seem to be declining week by week and month by month. And now, since you started them a few months ago, they're kind of the same. I don't see as much decline. So stability of the symptoms or slight improvements in the symptoms, I think both of those are wins. On the other hand, if you have someone come in and the family either describe side effects of the medicines, of course, or they say, it really just has not made a difference, that tells me we need to try something else.
So, speaking of side effects, the drugs get a bad name. One person takes a drug and they get side effects, and then everybody thinks that they're going to have the same side effects. So, how often or how common are side effects with these drugs?
So there are certain particular side effects. So the drugs that I call the cholinesterase inhibitors, donepezil, galantamine, rivastigmine. Biggest side effect is an upset stomach. So increasing this chemical acetylcholine in the brain can benefit thinking, but the drugs also slightly increase that chemical throughout the body, and then they can have other side effects like an upset stomach. Sometimes just some queasiness or loss of appetite, but sometimes nausea, vomiting, or diarrhea. In general, donepezil, for example, might cause that 10 or 15% of the time. Pretty similar with a drug called the rivastigmine patch. But other medications, the rivastigmine capsules, will cause that much more often. So we try to start with the drug that's least likely to cause it, and then, if not tolerated, switch to a different drug. Curiously, because the drugs don't all work exactly the same way, even though someone might not tolerate donepezil and might get nauseous, they might perfectly well tolerate one of the other drugs and not have an increased risk of side effects. So we do watch for GI side effects. Sometimes the drugs can cause a lightheadedness or dizziness, for example, or muscle cramps. In contrast, memantine sometimes will make people feel sleepy or actually even a little more confused, give them headaches, or dizziness, or constipation. But again, with all of these medications, we really try to warn people ahead of time what are the side effects to expect, write them down for patients when you see them, write them down for family members, and encourage them to call us if there is any concern for problems, and to stop the medication immediately. Even when people react very poorly to the medication, if you stop it, they're back to themselves within a day. So, watching for that. The other thing that we do, and not every doctor will do, is we titrate the medicines from a lower dose to a higher dose. You don't start at that full dose right away. You start at a low dose, make sure you're going to tolerate the medicine, get used to it, and then go to the higher dose. And that's often quite helpful in building up a better tolerance to the medicine. One thing we don't try to do is, if you're nauseous on the medicine, I don't try to give you an anti-nausea drug and put you on another medicine just to combat the side effects. My philosophy, particularly because we take care of older patients, is sometimes the least number of drugs, the better. And so if you get a side effect on the medicine, I'm going to try to switch you to something that you don't have a side effect on, rather than adding a drug to combat those side effects.
Yeah, that's a concern that we hear a lot from people. My mother especially, she's 92, and although she's not a medical doctor, she probably thinks she is. And she's convinced that any time you take a medicine, they're going to have 3 more pills to manage all the side effects. And it's really refreshing to hear that you have more arrows in your quiver, that you can switch to a different medication where there are no side effects. And even then, I was hearing you say that the side effects are not a given. Some people do not have them.
Yeah, I would say overall, a majority of people do not have side effects, but some people do. We try to make people aware of them ahead of time, and we monitor people for those side effects closely at each visit and in between visits.
Now, you had said about stopping the medication and they're back to themselves within a day. That's with respect to the side effects.
With respect to the side effects, right, yep.
And I just wanted to ask you, though, if somebody's been taking the medicine for a long period of time, and for whatever reason they stop taking it for 3 or 4 weeks, can they then start taking it again and no harm done, or do they lose the benefit? Because a lot of people don't appreciate the fact that you don't want to stop the medication without the doctor's knowledge.
Yeah, I think that's important. When people can take it, we usually do taper the medicine over several weeks' time. There's not usually really prominent withdrawal from these drugs, but just to minimize any problems, we would taper that over somewhere between 2 and 4 weeks' time. When people have been off the medication for more than a couple weeks, I usually will at least have a brief titration to try to bring them, starting at a low dose, to bring them up to speed again. The studies did suggest that for short periods of interruption, short meaning 3 weeks or less, people essentially got back to kind of where they were if they were off and then restarted the medication. But with longer periods of interruption, probably having to do with the fact that the disease progresses over time, people sometimes did not quite get back to where they were on resumption of the medicine. So, I would always say, if you have a problem, give me a call. Let me know what the problem is with the medicine so that we can adjust it rather than just trying to stop it on your own. And of course, like many medicines, if a little is good, more is not necessarily better. So, doubling or tripling up, that would have to be under a doctor's supervision so as to avoid side effects.
Great. Great. Well, I just want to take a minute and let people know about the resources that the Alzheimer's Association has, whether the diagnosis is just dementia and you don't have a specific diagnosis yet, or if the diagnosis is Alzheimer's or any other form of dementia. The Alzheimer's Association is here for you. The easiest way to get in touch with help is our 24/7 nationwide helpline. Call, put this into your cell phone, 800-272-3900. Trained specialists are standing by all the time to take your call. And if you would rather let your fingers do the walking like me, you can go to alz.org, and just about everything you could possibly think about is there on our website. So, Dr. Gittleman, we've answered most of the questions here through the presentation, but there is a question here about medical marijuana. Is there, and the question is, has it been shown to help people with Alzheimer's?
So no, there just is really no good data on that. American Academy of Neurology put out kind of a white paper on this, I think a year or so ago. Medical marijuana has been shown to help certain instances of multiple sclerosis, for example, or people with spasticity or chronic pain. In terms of the neurologic types of symptoms, but not yet for dementia. I do have some families who feel they gave people CBD oil and they're a little calmer, or they seem a little better, but there just isn't the clinical data there. So I don't personally, what I recommend to patients or what I feel has had some clinical backing to it. I don't usually recommend supplements, although most supplements are not likely to be harmful and if taken in moderation are fine. I don't personally recommend medical marijuana, although our patients on it, we note that and we follow them with it. And if a problem arises, obviously we're there to help them with that. But there just isn't that data yet. I do hope the studies are performed in coming years.
Okay, so the disease is the deterioration of brain cells. And you're telling us that there is no study, there's no science to suggest that medical marijuana or supplements or anything else is going to stop or reverse the deterioration and the death of these brain cells.
No, in a lot of these supplements that you'll see or medical marijuana, some experiments have been performed with mice or rats or for nerve cells in a Petri dish, for example, and they may say certain effects on the amyloid or how the animal is doing. People in the field will say we've cured Alzheimer's disease 100 times in the mouse, but not yet in the person because the underlying pathobiology is clearly different. The underlying metabolism is clearly different, even when those animals are genetically engineered to try to reproduce some of the underlying protein changes of Alzheimer's disease. So, and again, that's why it's been so hard. So, no, there are not the data yet to show that it's fundamentally altering what's happening pathologically in the brain, and there's not the data yet to show that it improves cognition or behavior. It may happen in the individual, but not at the point where I can recommend it, for particular symptoms.
Great. Great. Well, that is about all the time we have for today. Dr. Darren Gittleman, thank you so much for joining us. We really appreciate it. And if people wanted to get in touch with you, if they're in the Illinois area, that would be through your clinic.
Yes, absolutely.
And that is the Advocate Memory Center in Park Ridge, Illinois. All right. Well, thank you so much. I hope that all of you will join us again in a future webinar at alzwebinars.org. Have a great day.